formulaic approaches, and we'll discuss why I do that here as we go. But in hemodynamics, what is it? What is the purpose of it? What is our goal? That's a question for everybody.
Oh, you want us to respond?
Yeah.
This is gonna be one of those kind of classes.
Yeah, oh yeah, it's going to definitely be. And if I don't get answers, I start picking on people.
To make them hemodynamically stable.
Okay, that's too generic. What's your goal?
Maybe an answer.
It's all right. I mean, it's
We want to get them
specific.
dialed in so that they're, they're supporting their own functions, like that the heart's not working hard enough, but it's getting enough cardiac output out there, so that we're doing the body.
Okay. So mean dials demands for what?
For
oxygen.
perfusion, oxygenation.
Well, oxygen is priority, and I'll tell you why as we go through. This is one of the reasons why I draw things out too, is to build on that concept, because I think you need to understand how I'm approaching it. Because when I'm asking questions or you're seeing changes, that's going to determine how we converse. The more we're on board with one another, understand what we're doing, the faster that conversation will go, the faster we'll get down to the problem as well, versus having to ask a bunch of questions, or you're not sure how you turn something down, what it affected. What is the greatest derangement of hemodynamics? Cardiac arrest, right?
Mhm.
I know I write that out, but for you to think about why is it the most greatest? Because at that point, you'll hear me tell my patients' families, there's no blood flow anywhere. There's no oxygen delivery anywhere. Okay, that's important to understand. That's the greatest, worst situation. So why do we do CPR then?
Get oxygen
To where?
the brain, the vital organs.
Okay. Anywhere else? No, it's not actually. So in CPR, the priority is coronary perfusion. I know I'm splitting hairs here, but I'll explain why as we go. But it's still about oxygen delivery. Okay? Why is this the most important?
Because we want it to restart.
Exactly. So while the brain is important, don't get me wrong, we want the kidneys to function at the end, we want the brain to function at the end, but if the brain was going to be so good from our CPR, you wouldn't be doing targeted temperature management afterwards. So there's no way your CPR is adequate. Our goal is this. Why is this important? Beyond getting it started. Because it changes what you do. How does it change what you do? When do you perfuse the coronaries?
During diastole,
Which is when in the CPR cycle?
the release.
On recoil. But when you watch newbies doing CPR, and even some of you veterans,
There's no recoil.
there's zero recoil or minimal recoil. Why do auto pulses work so well? Consistency, both on rate, actually lack of fatigue, but also consistency or recoil. If you look at BLS and you dive into the document itself, they mention it. They don't put enough emphasis on it, in my opinion. But it wasn't until probably, maybe 5 years ago, 10 years ago, they actually started having a conversation about that. I actually started talking about coordinated perfusion pressure and why we do CPR. Why do we do CPR after we shock them?
To perfuse.
I hope everyone else hears that, right? That's not just in my head. Okay, just checking.
There's that little bug in there.
Hold on a second. Here's a gnat.
He must be friends with those 2 admissions from last night.
Crazy.
Maybe I
7
am.
grams of meth ingested.
That's where he went.
Oh, I saw that on Facebook.
We saw it about 4 hours before we got here. We were like, yep, these ours.
Sweet. There was that guy that left the hospital and was threatening to come back and shoot people, however it was like 2 months ago.
Yeah.
His picture was on the news. It was like, oh, he plays a really mean game of pool. He's a really nice guy. I don't know what the problem is. And I think Kara was sitting right there. She's like, what? You play pool with him? I go, no, I don't play pool. So recoil. Recoil is key, right? You don't perfuse the coronaries without recoil. Obviously, you need to do compression, push blood out into the aorta, but recoil is just as important. How does that change what you do? If you watch certain people, their goal is to try to shove blood up to the brain. That's how they do CPR. Compression, yes. It may not look that different, but if you really pay attention to them, if you really watch how the recoil, there's minimal. They may even stay on the chest, and the pressure is there, but there's barely any elevation. So just the simple concept of paying attention to this changes what you do. Okay? That's my point. Just simple concepts that we're going to talk about. You may not think that they're simple, but honestly, they actually are. Just because we put a formula up there doesn't mean it's something above you or whatever, but they are basic concepts. How you approach that concept changes how we do things. That's why oxygen delivery is paramount as an understanding. You're trying to get oxygen from the heart out to the tissue. Perfusion is important, and we'll get to that, but blood pressure and delivery don't always equate one another. Okay, and we'll talk about that as we go. But intriguingly, as you watch patients, as you watch people do CPR, are you paying attention to the person who's doing the recoil? So if you're understanding this perfusion, my hope is if this is a new idea or something that you didn't really pay attention to, now you're going to. So next time you watch someone doing CPR, there's always somebody late. Next time you watch somebody doing CPR,
Sorry.
just kidding, you're going to pay a little more attention. So as we make adjustments and as we hopefully set different kinds of goals, you're going to pay a little bit more attention as you change something. Why is that important? Because as you make a change to a medication, it doesn't go the way we're expecting it to. You're going to recognize that sooner when we have a conversation that's going to be part of the conversation, as opposed to their blood pressure is low and I turn the no-epi up. Okay. Okay? Everybody understand that? Any questions about that at all? Okay. So, delivery. You may have seen this formula before, you may not have. If you haven't, that's okay. No big deal. It's cardiac output times oxygen content. So it's whatever obviously cardiac output is at that time, multiplied by whatever oxygen content is within the blood at that time. Okay. Break that out further. That's all times okay, you're like, what the who gives a shit? I've done this for a few years, so that's why I can memorize it. The thing, mathematically, this is something we came up with as we did Swan-Ganz in patients. This is something that over the years people have tried to, as a way of trying to understand physiology. This doesn't tell you what happens at the capillary level. This doesn't tell you how the cells absorb or don't absorb oxygen, which is irrelevant. But conceptually, what we're doing and what we manipulate is this, and this. We can manipulate this, but when you look at for this from a mathematical standpoint, a person would have to be in a hyperbaric chamber. Done it. When I was a fellow, we had a person with hemoglobin of 3. Stuck them in the hyperbaric chamber because they didn't want blood. They were Jehovah's Witness. It was the only thing that kept them alive. So from a formula standpoint, do I sit down and calculate this? No. Have I ever? No. Do I make residents do it? Yes. Because it's fun. It makes me happy. But all the studies that have been done where they looked at actually trying to optimize this, give everyone 600 mils per minute, I think is what the goal was. There's no definitive outcome benefit. Taking everyone to the same level is not appropriate. But conceptually, it still tells you where we intervene. Obviously, their heart rate's 20. We know where the problem is. Not really hard to recognize. This one is the more challenging one. That's why we have monitors that we're using. This one is obviously, we know this one pretty well. But there's also a lot of debate about how and when, why we have restricted transfusion practices, the choice of agent that you use. This one, you can't mess with very much, but it should tell you one thing. Despite these being perfect, when our COVID patient SAT is in the 60s, their oxygen delivery is compromised. It's why they're breathing fast. It's why they can barely fart without desaturating, right? So they're still compromised. They may not be in shock like we might define it, but they are hypoxemic. So their cells are in danger. They don't have enough energy. The heart's gonna suffer. So, the brain's gonna suffer, right? So these are them to be the ones that we manipulate. Again, back to when you start looking at that patient and you're asking yourself, what's wrong with them? Forget having a monitor on them. You just see a blood pressure. We'll get to the formula for that here in a minute. What's the cause? And we always will tend to jump to fluids, which is fine because we're always assuming it's a preload problem, but it's not always the problem. What happens when you give them fluid and there's no response? What happens when their heart rate is 70 and you're like, well, that's fine. Is it in the face of what they're facing? and the illness that they're facing and the stress that they're facing. Their heart rate's 90. They're breathing 40 times a minute. That doesn't make any sense. If you don't believe that, why don't we run out to the stairs, run up and down 10 times. Let me see what your pulse is. Let me see how fast you're breathing. Okay? These are also compensations. So we should compensate in the face of stress. The other is, this is what we live with every day. This is what we do all the time. Okay? We're seeing physical derangements. We're seeing patients that have reached some pathologic state that this is becoming a problem. Okay? But this is how we normally act. This is how our bodies normally act constantly. So think in terms of compensations are just as important. So when you recognize that there's no compensation. And we'll talk about blood pressure relationship here in a second. Any questions about this? So as you look at this formula, I want you to start thinking about what you do for intervention. Obviously, transfusion is pretty straightforward. But how you intervene and why you intervene and the responses you're looking for intervention. Okay? So the big place where we interact with the patient, obviously, is the lower pressure patient. But the higher pressure patient is just as cold. But the relationship for pressure, original formula, which came out of Swan-Ganz catheters, was SVR is equal to MAP divided by cardiac output. Okay? Mathematically, then cardiac output times SVR, TPR, whatever the hell you want to call it. So you can see the relationship from a blood pressure standpoint. If this is fixed and this goes up, that's going to go up. Again, are we going to sit there and calculate this stuff? No. But we use it. It's in every one of our monitors, some relationship. We obviously get this most of the time. This is a number. If you really plug it in mathematically, for me it's negligible. I can put 0, I can put 20. It's not going to change my number very much. I think about 200 points is about the difference. Right? So you can do it, we can use it. I don't ever use it. I don't care to use it. CVP's value for me is very low. But in terms of anytime that you're adding an inotrope, anytime that you're adding some kind of pressor, that's what's going to end up with this result. And so as we use Starling monitors, we use FlowTrack, these are the things that we're manipulating. Okay? So when you are messing with your pressors, titrating your pressors. Yes. Then your question should always be, what happened when I did it? So I have gotten phone calls since I've been here. So-and-so's blood pressure's done, I changed this, whatever, and no comment on these when they're there. Or document only this and not this. Both of those have to be present. The relationship between those are imperative. So if you have a patient, we've all seen anaphylactic shock. If I was to measure those numbers, what would they be? I don't need the absolute number, high or low, what's the relationship? This in an anaphylactic shock patient.
It's different than like in septic shock, but I can't remember. I think your SVR is...
Classically, it's not actually. They're both a distributive shock.
Okay.
Classically. So what will your numbers be? Cardiac output would be high or low?
Low.
No, high. SVR high or low? Low. Why? Yeah. Why? Do you guys know? So when a person has anaphylaxis, IgEs interacts with whatever antigen that they've been exposed to, peanut allergy, let's say, and histamine's released. Histamine causes to vasodilate. It's the reasons why patients get low blood pressure when you give them narcotics, especially with morphine. But it's massive. I mean, it's bodily. What happens to their heart rate?
Jumps.
Because they're compensating.
Because they're compensating. That is a normal reaction. Anyone here take hot showers? You ever notice your heart rate go up? Why?
Because you're dilated.
Yeah, you're also trying to overcome heat, but you're vasodilated. It's a normal compensation. So you have a septic shock patient with a heart rate of 70. Doesn't make any sense. Compensatory wise, it's not an appropriate reaction. You have a person who's hemorrhaged, heart rate's 80. Doesn't make sense. It's a compensatory reaction, right? Our job is, our body is, while it's trying to improve delivery, it is wanting to maintain perfusion. So delivery, in general, oops, sorry, let me throw that. Delivery is from here to here. Perfusion is a difference between these two. Okay? If the cells are not getting enough oxygen, they're going to reach back and demand more. Just the way they're going to be. It's why the kidneys respond the way they do. But your perfusion pressure through any organ is going to be contingent upon the MAP and what the pressure going out of that capillary bed is. So in the anaphylactic shock patient, you have gross vasodilation, the body knows what it wants to maintain. Sometimes it can't. Sometimes they'll be tacky and their pressure will be normal. They'll look like shit, but their pressure will be normal because they're otherwise young and healthy, and they can maintain a cardiac output of 8 or 9 for a period of time because they are able to, if they have enough blood volume to do it. Over time, it won't last. They'll get more shorter breath during that time frame, some of it because of bronchospasm, some of it's because of shunting of blood, which is another conversation. But in general, compensation should occur. So septic shock, at its classic, is supposed to be a high cardiac output, low SVR also. But the reality is any one of these shocky states does whatever the hell it wants. We can make assumptions, we can act on those assumptions, and when what we do doesn't work, we have to be ready to suspect there's something else going on. And that's where understanding this formula, as you make adjustments to a pressor and you increase the norepi and things didn't go the way we thought they were going to go, maybe it's not a vasodilated state. The lady I had back in, I don't know if she's still there now, but she was in 8. So we intubated her, put the Starling on her. Her cardiac index was, I think, 2.1, and her SVR was 1,500 to 1,800 on norepi at 20. It brought her pressure up, but that SVR shouldn't be that high. What is that? What would be an SVR? What do you consider to be a normal SVR?
812.
Okay. Sure. So I encourage, especially if you're new to hemodynamics, pick a number. I use 1,000. And it's not that 1,000 is perfect, and it's not going to be in every single person. But if I'm above 1,000, I'm more relatively contracted. If I'm below 1,000, I'm more relatively dilated. Okay, it's like 7.4 for your pH. If you're 739, you're more acidotic. 741 is more basic, even though that's in the normal range. So even though 900 is the normal range, you're still more relatively dilated. If I am a septic shock patient, what should their number look like? 400, 200. So I had her on pressors with an SVR of 1,500. What have I done to her? Yeah, what am I doing? I'm killing her kidneys. I'm killing her splanchnic circulation. The GI system will take a hit. I'm not fixing the underlying problem. If I didn't have the monitor in place, I would never have known that. Okay, pressure was better, heart was whatever, pleth was maybe a little bit flat. So that's where understanding what we're doing and realizing that the interaction of the medications, what we're using, may not be what we think, but you should be looking for a result. So we may start with just norepinephrine right off the bat, and it just doesn't get them where they need to be, or they don't have a heart response that you would expect, or they're a little more cool and clammy that you'd expect for that vasopressor, okay? Or if you have an art line in place, it starts dropping, it starts becoming more dampened or something. Your recognition and understanding of this formula interaction is imperative, and as we choose medications, so on and so forth, right? When I was over in Kirksville, one of my best cases I thought was a guy who I thought was a bowel obstruction. I walked into him that morning. They had been giving him fluids for the course of the night. They sucked out about 5 liters out of his GI system with an NG tube, and they replaced about 4.5 liters, 5 liters, but he was AFib RVR, heart was 130, blood pressure was holding around 90. And so I immediately started him on norepinephrine at 8 mics, 10 mics, I think it was. Okay, what is the other reason for trying to treat shot right off the bat? What are we trying to prevent? Goes back to perspective and goal,
The crack.
which is what? You're right, which is what? Cardiac arrest. At its worst, shock leads to cardiac arrest. People say, well, kidney function. Like, yeah, you're right. We don't want organ dysfunction, but honestly, multi-organ system failure is a late finding. If you treat them correctly, aggressively early, that's why we're so aggressive in sepsis. If you prevent the shocky state from deteriorating, worst case cardiac arrest, then obviously you might prevent the future things. But cardiac arrest in these patients, all of our patients are typically older, 65 or up, especially in the septic population. Everyone's got some sort of coronary disease. You drop their diastolic pressure enough, they're going to have a heart attack. It's a type 2, but they can still arrest. So when we see those PVCs occasionally, we see those arrhythmias occasionally, some of that's coronary perfusion. But in this guy's case, he was older, had major comorbidities, that's why I did it. Started 8 mics, didn't really do much, put an Arvine in him, hooked up to flow track, his SVR was 200. So they've been operating, and he was a hypovolemic shock the entire night, didn't escalate like they probably needed to. Hindsight's always 20/20, so I took him from 8 mics to 25 mics on Norepi in one shot. All of a sudden, he went from wanting to die and telling me he wanted us to stop everything to giving me shit about my beard and joking with me. Heart rate also came down to 70. He converted normal sinus rhythm. So his AFib RVR was compensatory to gross vasodilation. Okay, so they started down one path, it wasn't working. 5-6 liters later and no improvement. Hypovolemia may not be the primary cause. Okay? So, in terms of manipulating these numbers, well, actually, let's talk about this one more time here. So this example is really applies to any capillary bed. So what other examples would you imagine? I mean, this is MAP and CVP is global. That's global pressure. What about local pressure? So in the head, it's MAP minus ICP. In the belly, it's MAP minus abdominal pressure. So we start talking abdominal compartment syndrome by example. We may have enough delivery again to some place, but because this pressure is elevated, we have other problems. So while hemodynamics may apply to delivery of aspects, perfusion is not just what their blood pressure is. Perfusion is also what's their venous pressure. And so you might say, well, you don't use CVP. No, I don't, because it doesn't tell me local. It tells me global. It's one reason why most medical ICU patients with abdominal compartment syndrome die, if you look at the studies that are out there, because most medical people aren't trained in abdominal compartment syndrome. Why? I don't know. I learned it mainly in the surgical intensive care unit. Maybe that's why, but it does exist. If you've seen enough post-cardiac arrest patients, how many times have they blown up like a jiffy pop? Why'd that happen? Because they lost blood flow their entire body, including their splenic circulation. They just created a ischemic bowel, and now their belly is blowing up like a balloon. Right? They may have saved them through one thing, they're dead from something else. Right? It goes back to, again, delivery to an area. But as that rises, or that whenever pressure rises, there's other perfusion issues that we have to be considerate of. Okay? So if you don't see the urine output improve like you would like, that's one thing. If you don't see ventilation improve like you like, it might be another. And while we don't see a lot of head trauma patients, the 24-year-old we took care of, we actually increased his ICP with our management of his hemodynamics. We worsened his ICP initially. Yeah, right? So once we brought his numbers down, we drove ICP based on our pressure, not because of what was going on intrinsically. Okay? Any questions about that? There's something else I was going to say. Okay. So I'm not hearing a lot of questions. Do I need to start asking?
It's making sense what you're saying. That's why I'm hearing.
Yeah, good excuse. That's good.
Don't get 20 years in without having to come back.
It's all right. Sir.
Not having knowledge, but a good comeback.
Hey, sarcasm is a learned trait.
It is.
It is a learned trait. Unfortunately, my 15-year-old daughter has learned it very quickly.
Oops. Gee, I wonder where she gets it from.
I don't know. I have no idea. Her mom must be really rude to her. I don't know. Sometimes she'll say things and I'm like, you know, I really want to be angry at you, but that was pretty good. I'm proud of you, honey. Don't say it to me. Seriously, what other questions? Anything? Matt? Go ahead, man.
I've got nothing right now.
Oh, kill me.
When we get like maybe 4 hours of sleep, I'll come back with something.
Right.
Okay. Heart rate. This may seem pretty easy. What drugs do we use? Beat you to one. Atropine. What else? Adenosine? To bring it up?
No, I said dope.
Oh, dopamine.
I
Okay.
did say it didn't.
What else to bring it up? What else?
Happy? Mm.
You're killing it. Keep going.
As a Prodernal, I can't spell it. Anything else?
I never thought about the last two in the first place, so.
Norepi. Okay. Sure.
Sure.
Beta 1
I might as well
agonist.
throw that in there.
Oh, it's got beta 1 agonist. Is it something you're going to jump to? No. Why? Because it's not isolated. That one's not isolated. This one is. This one is. This one is. So in terms of if you believe heart rate is part of the problem, and we're not talking about tachyarrhythmias, bradyarrhythmias, or it's not enough of a heart rate which you expect from a compensation standpoint, there's really only isolated medications that will target it. So what's a general concept in hemodynamic management? The minimal effective dose of anything that you're using. Okay, just because 20 mics works doesn't mean it has to stay at 20 mics. Just because 1 mic works doesn't mean you have to go up. Okay, what's a starting dose for dopamine? 5? How about 1? I started a patient on 1, they went to a tachyarrhythmia before. Any medication has toxicity, regardless of what they want to talk about in terms of this is the range for this is the range for that. Bullshit. Every patient, you have no idea. So starting at the minimal effective dose possible to get you what you need. What should be the expectation? I may not even want to see heart rate. Let's say their heart rate's 70. Do I really care if the heart rate is 75? What am I looking for? I want to see a rise in blood pressure. I want to see that I'm increasing this somehow by looking at this. Because if this is held steady, potentially if I just improve this, this is going up. Because maybe I didn't affect heart rate. Maybe I've just affected contractility. Okay. Obviously the heart rate's 20, different conversation. That's kind of duh. 25 is not adequate. 40 might be a good goal. 50 maybe a little better. But remember, anytime that you use these medications, what's the risk? Now they're in VTAC. Or the heart rate was 70, now they're AFib RVR. So we ran into with a lady about 8. So we can make it worse. That's key. You gotta remember, you can make it worse. But the more you can be targeted to something, the better. Obviously, we're not gonna run an atropine drip. Ephedrine's one we don't mess with very much, but which I think we need to get more in the habit of. It's kind of like a bolus version of Norepi. But the anesthesiologist will use it frequently with some success in the OR. And I had a person I resuscitated through the course of the night who had 1 IV, couldn't hang Norepi. They didn't want a central line for whatever reason. But 4 boluses of 4 milligrams at a time was enough to keep them off any kind of pressor. So, again, options and understanding what you're facing. But beta 1, alpha 1, beta 1, alpha 1, primary beta 1, beta 1, alpha 1, beta 1, beta 1, alpha 1, dopaminergic, but also beta 1, alpha 1, and then anticholinergic. Right? Well, understanding the drug that you're choosing or making a recommendation to I think is also contingent upon recognition of response. We started their epi, we're at 15 mics, heart rate sitting in the 70s. You have your monitor on, it shows that your SVR is still 800, but your index is in the toilet. They have no variation. You've given them fluid boluses, and then you call me up and you say, what? I think they'd benefit from some dopamine. Why? I've given them fluid boluses, Norepi's at a pretty decent dose, SVR is 900, but I haven't had no budge in my cardiac output. Good thought, let's start it. Also, a lot of these patients come in on what? Beta blockers. So they've already come in, they're on beta blockers or cardizem, calcium channel blockers. So we're competing with those things in some cases. You can make the argument that a patient that comes in septic shock, let's say, that is on beta blocker, has no heart rate rise, is also cardiogenic shock, medication induced, right? Because the heart's not mounting the response it's supposed to. And that's the definition. The heart can't meet the demands of the body. Delivery can be a variety of other reasons, but in this case, the heart cannot increase contractility. That's a limiting factor. And we might have to start dobutamine right off the bat just because, right? So, stroke volume. I'll beat you to it. Fluids, what else? Specific. Dobutamine. Milrinone. That's the end of your inotropes. What next? Epi. Specifically, Norepi. Can't say depressors. Does it? No. It's an alpha 1 only. It doesn't improve contractility. Vaso? No. What else? Ephedrine. Anything else? Isoproterenol. Anything that has a beta 1 stimulation. Now, there is some argument you might see an improvement in cardiac output with phenylephrine, but it's compensatory bradyarrhythmia most of the time.
Apologize. Transmitters for Cerebell? They're off the counter. They're not there. Anybody have them?
Ask Kristen and Tracy.
Okay.
They called me last night. Kristen and Tracy.
Phenylephrine will decrease something called venous capacitance. So the venous side of our system will dilate for a variety of reasons, and it can hold upwards of 2/3 of your blood. So if you squeeze down the venous side, you actually give basically a bolus of fluid, so you might see an improvement in cardiac output. Problem is, for MAP, you might increase this. If you increase this above this, then you just change your perfusion. When I was a fellow, I had a patient, came back from the OR. Of course, the OR, they always love to use phenylephrine because they think everyone's vasodilated, and they're not. And their pressure was fine, but if you watch they were in the OR, I think, for 5 hours, and they checked the blood gas about every 2, you can see the base deficit worsening. When they got to us, phenylephrine was basically wide open. Someone, whatever, decided to turn it off. I left the room, patient looked good. I didn't pay attention to the laboratory. Got called back into the room, now the pressure was in the 60s. Lactate went from nothing to 15, and so there our normal elevated was 2. So here that would have been probably 80. So what had happened is they had squeezed down their perfusion of all their organs because they were squeezing the CVP, supported the blood pressure artificially, and basically made everything ischemic. So it's an okay medication, but it's definitely not a first line by any stretch of the means, and it's primarily an afterload effector, so SVR effector.
So it's not a drip, but what about the use of like calcium for increased contractility?
You can. No, you can. I mean, if you think that they're low. I mean, as far as jumping to it by itself, no. I mean, just because.
In conjunction with.
Yeah, I mean, if you see their calcium's low, sure, nothing's going to hurt.
Like the open I just had the other night, we had him, he was on epi and norepi, and I was chasing my SVR all night long because it was low and I couldn't get it to come up.
Okay.
He was running 400, 500. You know, my maps I could bear, you know, he was soft. My index stayed 2.2 to 2.4, and so I think, and with his morning labs, his serum calcium was low. So I was pushing for at least a gram of calcium or more,
Sure.
and didn't get what I wanted, but it wasn't a bad thought.
No, not at all. If you see calcium's low, sure, we've seen it before. Why are they dilated though? That's another intriguing thing. We're talking about pressors, but what else could you use? So let's move on. Well, so beyond, let's come back to that. So stroke volume, fluids.
So you said with stroke volume, it's more beta.
If you want contractility, beta 1 receptors are responsible for that. Alpha 1 is always peripheral constriction. That's where if you constrict them down too much, you can cause decreases in your cardiac index. So some of the studies actually in transfusing blood have shown drops in cardiac index with transfusion. So free heme in blood binds nitric oxide. Nitric oxide is a vasodilator. So if you bind it down across the body, you'll see drops in their index. But so in terms of fluids, this is where your passive leg raise, SVV are two main things that we use in terms of a vented patient, a non-vented patient, right? There are other parameters out there. I've shown some of you plethysmography. If you look at the pleth for their sat, if you stand back far enough as they're breathing on the vent, you can see variation in that as well. It's no different because the pleth waveform is cardiac output. That's all cardiac output. Saturation notwithstanding.
It's a stupid question. Go into that.
There's no stupid questions.
The pleth waveform. Explain that to me.
Okay, so what are you measuring?
I don't know. That's why I'm asking you to explain it to
Well,
me.
you have a sat monitor on a person. What are you measuring?
Their peripheral oxygenation.
Okay, so you're checking the saturation on blood with the infrared light, but what's the waveform? Yeah, it matches their pulse. Pulse of what? Their capillary bed. So the pulsatile nature of flow through a capillary bed is no different than a thermal dilution curve. For those of you that have seen thermal dilution curves on swans. Have you seen one? Have you read one? Okay, so back in the day when swans were used thermal dilution, you would inject cold, if the swan was here, you inject cold fluid here, and then a thermistor would be here, and you develop a waveform. This is cardiac output. This is contraction of the ventricle, and then diastole of the ventricle. That's the total amount of blood ejected per beat. Over time, that was calculated, variety, whatever. I think it's the Fick equation is what they used, but it's no different than this. This is a rise and drop of blood flow, a bolus of blood going through the capillary per beat. How much? I don't care. But when you look at it from a positive pressure ventilation, if you have a good waveform, you can see variation if they're hypovolemic. That's no different than stroke volume variation, what we use here. Same thing. Same thing with what the Starling monitors. Okay? They're looking for changes in cardiac output or stroke volume over time with a change in fluid. So if you give fluid and you see a rise in cardiac output by 10% based on their data, that may be an indication that the heart is responsive to getting a fluid challenge. That's what that variation is supposed to represent. You gotta have a good pleth. And there's a plethysmography variation index that a machine will calculate, but screw it. I mean, conceptually, you can look at it, you can see it. Sometimes it's very, very obvious. Sometimes it's not. If it's not, it may not be the case. But eyeballing and trying to come up with some kind of parameter that tells me, hey, they may benefit from this, or they may benefit from stimulating this, or they may benefit from this, is what we're here to talk about. How do you make the choice to choose something or ask for something or recognize something may be needed? You're seeing that at bedside, I'm not, unless I'm standing there myself. So I'm down the hall, you need something else, you're like, hey, I tried blah, 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 and I think I'm down to this. Perfect, sounds great, let me check just to verify, yep, I see what you're saying, start it. Okay. That speeds our conversation, that speeds our resuscitation. You see calcium's low, yeah, sounds good, give it. I don't know of any contraindication in giving a single dose of IV calcium. If it improves things, but that's not going to fix your vasodilation. It may be a contributor. It's not the primary problem. You should have had vasopressin. That should have been added. Or, what else? Steroids. So vasodilated shock is also adrenal insufficiency. I didn't really talk about that yesterday, but Addison's disease or relative adrenal insufficiency also will lead to a vasodilated state. Okay? But it's also the recognition there is a vasodilated state. Yeah, if you call me up and say, I'm on epi and norepi and their SVR is still 400. What? Okay. What's your dose? What dose in Norepi were you on? Do you remember? How much Norepi?
I was at 3,
3.
just 3 mics.
Oh shit. How big were they?
It's an Arnold patient.
I understand. How
He
big?
was 400 pounds.
4. Okay.
He's great, actually. He's doing great.
Okay. What fixed your parameters?
I don't
Time.
know, because I went home. So, when I went home, so I'd been up to, I think, close to 10 mics on the Levofed to tighten them up. And then he'd gotten a total of 4 liters of fluid over before I got there that day, and then the epi was running. So over the course of the night, his SVR came up to 800s for me. His heart rate stayed in the 90s, and then his pressures kind of stabilized. Maps were running high 60s, and so talked to Arnold before I left, and he did another liter of fluid and wanted them to start tapering off the epi before tapering off the levo.
Okay. And what were you running to monitor his numbers?
Yeah, I just wanted still his first night post-op.
Okay. So, okay, SVR. Remember I told you 1,000? Yeah, I know there's a range. Just keep that in your head, for those, especially those of you that aren't used to using it. Just 1,000. Don't worry about the range. Just remember that number. So, how do you treat SVR?
You gotta tighten them up.
Well, Norepi.
Norepi.
What's an average dose for Norepi?
Just start at 4 is what I start at, but it depends on the size of the patient.
Every one of your studies, 0.25 mics per kilo per minute.
Are we talking about increasing SVR here?
No, I'm saying in general, from a
This is
treatment
different.
standpoint, if you're trying to fix SVR, you have a low, there it's low in this case. We're not gonna talk about necessarily dilating, which we can, but in terms of a shock patient, we think the SVR is the problem. 0.25 mics per kilo. So 3 mics and a 400 pounder is pissing in the wind. I think it's also ideal body weight. I imagine 400 was not their ideal body weight, unless they're a elephant.
51 mics.
Yeah. So remember the gentleman I told you went from 8 mics to 25 mics? I got some strange looks, but he was 100 kilos. And he was a stout individual. I mean, it was not a overstatement to say he was 100 kilos. And it fixed him. So I run 45 mics on people without batting an eye if it does the job. So we get, I myself, having run per minute back when I was over in Kirksville, I got always sketchy around 15. But when I was a fellow, I guess I didn't pay attention. We were using mics per kilo the entire time. I didn't really calculate out how much we were giving people. I had a gentleman once that was on 0.45 mics per kilo and 0.45 mics per kilo of epi, both. So 45 of each. The GI bleed we had, I think, was on 55 mics of both. And then we added something called methylene blue, which is what kind of got him out of it. So the pressor itself was, excessive at times. We feel it's excessive. The danger being what obviously is apparent. But again, bringing up SVR, other options, we said epi. Early in my training, epi meant the patient was going to die. Now, obviously in septic shock patients, it's second line. Dopamine, I don't know the last time I used it. Probably in 10 years. Small amounts of it for bringing heart rate up, I think, aren't unreasonable. But data outcome, while there's very little in cardiac arrest victims, in shock victims, these are the best drugs to use. Vasopressin, how's it work? No, sensitizes vascular tissue. It's not directly at the kidney. So in terms of the pressor utilization, you're sensitizing vessels. It's like using metformin in diabetes. So when a person's on enough Norepi that we say, hey, maybe we should try vasopressin, right? I would ask, when did you decide to try it? How do you know when it's not really doing what you want?
I don't have a map.
Based on how much dose, 3 mics? So So my encouragement to the group, I've tried to get in the habit of, this is what I calculate in my head. If I've achieved this goal and we're not achieving goal, I'm going to that. I may even go to it sooner. But I'm trying to, in my mind, in your minds, set a limit. Something, not just, well, they're on a lot. I mean, the whole point is to have a conversation so we can fine tune this down to a consistent practice, so that any of us at any time will act arguably similarly or make suggestions similarly. When we have monitors in place, it's a little different ballgame. Maybe it's also, if we reach this point, we should start adding a monitor if we don't already have one hooked up. Maybe we should start adding an art line if we don't already have one hooked up. I've had several cases now where I placed art lines femorally because I couldn't get anything peripherally, pressure was 60 over whatever, femoral art line said 140 over 80. I'm like, oh, I think they're a little bit constricted. So we changed some practices and got things a little bit better, but sometimes you're not picking up peripherally by manual because they're just so constricted peripherally, not because their pressure's that low. We start cranking the pressors up, we make things worse. So I would encourage you to keep this number in mind. You have to calculate every time. Yeah. Get an idea when you first start out. What's their average dose? If I reach this number, I'm calling because it's not working. Okay. So I occasionally will 0.125. If I'm looking at somebody with 12 mics for 100 kilo person, if I even start there and see if that's enough to get them under control. If it's not, I'm escalating and thinking about adding this right off the bat. But vasopressin works on, I think it's VA1 receptors. It sensitizes potassium and calcium influx into the cells. So your blood vessels require calcium for contraction. So like she mentioned about the hypocalcemic patient, vasopressin can help with that a little bit. What's the dose? Can you titrate it?
No, usually don't.
You can. So VAST trial from 2008, 10, 0.01 to 0.03 was the dose range. Minimal effective dose. There's no reason to run 0.04 the entire time. Anything above 0.04 squeezes the coronaries. FYI. I've seen that go higher. Don't ever do that on my patients. You also can destroy their splenic circulation, cause all kinds of GI havoc. But the whole job of it is to sensitize the tissue to the norepinephrine in their system already. So the VAST trial, if you need it, I can send it to you. I can send you multiple articles, 0.01 to 0.03. And it was comparable to norepinephrine in some of the populations, even as a first-line agent. Okay. So titrating down to 0.01, what should you see in response here? This goes back to if you have a monitor in place, and this is running 400, and you crank up your norepi, you should see that go up. If it didn't go up, well, it didn't work. If it does go up, well, then it worked.
This guy had
Vasoplegia? Sure.
related to the procedure and the ECMO and everything. So
Sure.
that's why we didn't titrate. That's why I wasn't titrating Levophed, because we weren't having the effect on it. And Dr. Arnold doesn't like to. He likes to have specific numbers. Like he doesn't give the bedside nurse much freedom to titrate
Sure.
because it's different line of surgery.
Okay.
That's the story I'm going with.
I hear you. So to that extent, an SVR 400 is not adequate. 800 is probably a lower limit. 600 would probably be even a lower limit you could use from a goal standpoint. If you're trying to see goals, seeing some kind of change, 3 mics is not a lot. And if you haven't achieved, but the other is looking at what your perfusion at other places are. If that patient's wide awake and talking to you, then you're probably okay.
Yeah. People in the drawing room have a conversation.
Then you don't necessarily have to, there's a problem with numbers too, is we manage by inertia sometimes. We're trying to drive things like we're gonna fix this person, and we're not. You have to remember in some cases, all you gotta do is provide the base minimal for that person at that time, just enough to maintain, and their body will do what it's gonna do. Occasionally you gotta kick things up, occasionally you gotta recognize when to turn things down. Our biggest negative is not knowing when to turn things down. Okay, it's easy to crank them up. Do you turn vasopressin down first or norepi first? I've been asked this question multiple times.
I feel like the answer is to get your levo down in the vaso last,
Okay.
but I don't remember the why. Was it you I was talking to? I don't remember
Might
who I was
be me.
talking to about.
I try to
Probably.
find levo down first until I'm at a more reasonable number, like 8 to 10, and then I'll start to titrate my vaso
Okay. Why?
off.
It's all right.
It just makes sense. Less medication is better, and it doesn't make sense to turn my vaso off when I'm still on like 20 or 25 mics of levo.
Sure. Well,
'Cause
why?
I had to
But why
add it.
turn your vasal down if your therapy's not off yet? So if you look back at the earlier studies, if you get bored, look them up. The original vasopressin studies were because of just finding some adjunct for norepinephrine. And then physiologically they found that it sensitizes the tissue. So is your norepinephrine level high or low when you're in shock in your body? It's high, massively, massively high. Your body just can't do it for whatever reason. Pathology being what it is, tissue insensitivity being what it is, for whatever reason your body's not reacting to it the way it should. So we're adding super physiologic doses of a drug to try to maintain a person, whatever that reason may be. Okay? That's why if you have a person that's SVR is 2500, adding norepinephrine isn't a good thing necessarily. You might to maintain diastolic pressure because you're trying to maintain coronary perfusion at that point, but you're killing them with it. You're squeezing down their splenic circulation, you're destroying their kidneys, you're gonna kill them if you don't fix the underlying problem. Whether it be put them on a balloon pump, go in the cath lab, put them on dobutamine, whatever the problem may be, give them fluids, whatever the problem may be. Okay? But you have plenty of shocky patients that it's very high. SVR is. Where's it coming from? It's coming from norepinephrine in their system. In a septic shock population, it's a different beast. You have norepinephrine that's at high levels, but you have nitric oxide that's vasodilated. You have endotoxin that's affecting directly on tissue. You have usually malnourished people because they've been sick for 2 or 3 days. They're hypovolemic, obviously, and they've depleted their system of vasopressin. That's one of the reasons why they went after this drug. So when they looked at the patients, they measured their vasopressin levels, and it went away. It was gone. Vasopressin's primary job is osmolality. It's free water retention. That's its primary function. It's pituitary driven. But when in shock, its job is to also help vascular tissue. There's also some permissive nature of ACTH release, which helps with adrenals. Again, not something you necessarily have to worry about. You'd be like, oh yeah, well that's why no, whatever. Reason why it was chosen, reason why it was investigated was those reasons. But when you add it, you're trying to augment your norepinephrine. So the idea, even in the VAST trial, they compared norepinephrine against vasopressin as a primary medication. It was equivocal. The study was equivocal. You can start vasal by itself. Patients did fine. They actually had better renal issues. The recommendations, I'm still not sure I understand, because when you read the article, it was equivocal. So why couldn't you use either? Whatever. I mean, the guidelines are what they are at this point. But do you turn it off first or second? I've heard mixed conversations about this. I turn it off second, mainly because of what you said. We're trying to sensitize the area. But the other is, it doesn't really change outcomes. What it does is it cuts down on how many times you have to intervene. So comparative studies, if you get a chance to look that up, no real difference in outcomes. It just means when you turn off norepi second, you're having to react more frequently to hypotension. If you go off first with norepi, you have less episodes of them dropping their pressure as you're trying to work these things down. So at a bedside standpoint, it makes it easier on you as far as having to, oh, they're down again, we gotta go back up. Okay? But again, as you're messing with it, you should be looking here. So you should ask yourself, when you turn norepi down and their pressure is perfectly where you want it to be, what is their SVR at that time? If their SVR is 600, well, there's kind of your sweet spot or where you want to be. Let that be your guide. You're sitting there on the same pressors and all of a sudden something changes. Your numbers change dramatically. What happened? Ask yourself what happened at that time. Did you give them a dose of fentanyl? What's fentanyl going to do to those numbers?
Your SVR is going to go down.
And your cardiac output. It's going to affect both. It's a sympatholytic, so it affects the sympathetic nervous system, which is your norepinephrine. So you might see both those numbers go down. And so then when you look at it and you see, and you don't have to call me and say, oh no, their pressure's down. Yep, I gave that phenylephrine because they're having some pain, or the fentanyl because they're having some pain. My numbers all dropped, I had to go back up, but I know exactly why that happened. Okay, you can draw that connection if you have those things in place. But if you don't have those things in place, we're on our pressor, we're just on a little bit of norepinephrine, things get a little bit worse. Understand how your medications that you administer cause the problem. Why do we use fentanyl for shocky patients over, say, morphine?
Does it have less of a vasodilator effect?
Yep. You know how? It's histamine. So morphine will dump people's pressures. You've seen it. You know you have. The whole reason why anesthesia uses fentanyl over everything else is the hemodynamic benefits. Whereas hydromorphone is kind of halfway in between. So again, pay attention to hemodynamically. Doesn't necessarily be that we're in a shocky state. You have a person that is on the vent, they're doing fine, we're on no pressors, and you do something to them. What is it you did to them that made things change?
Mm-hmm.
Or there's some change and you didn't do anything to them. What's changed? Maybe their belly pressure is starting to rise. You start seeing some variation. You hook up the Starling and now there's no blood loss. Their fluid intake is actually on the positive side, and now you're seeing variation. What's the problem? Looking for reasons why these things may be aberrant. My encouragement still is mentally, what is it? Which one of these parameters are we affecting? And so as you go looking for causes and you see that, yeah, their belly is taut, they have not had a bowel movement, they're pretty tympanic, or the urine output's dropped off, or their ventilation's changed, or RT came through, or I came through and increased PEEP, or something that happened, you're asking yourself, which one of these things did we affect? Or you're noticing, even despite there be a normal pulse on telly, every other beat on the pleth, draw up here, is gone. We had that happen on somebody. They'd have a PVC, they were by Gemini or whatever, but every other beat was non-perfusing. Looking for those things. That's the point of these conversations, and that's the point, for me, in my mind, the formula is give yourself structure to why you look through something, as opposed to just, well, things look bad. Call Whalen, call Rickelman. It's low. I think it's up. It's down. I don't know. Okay. The more you can get down to that, the better it's going to be. Okay. What else for SVR? Phenylephrine. This is where it falls. It's an alpha-1 agonist, straight alpha-1 agonist. Can cause some compensatory bradyarrhythmias, mainly because you're squeezing SVR down to the point where your body's trying to compensate by slowing down. So it's not a first-line agent by any stretch of the means, and there's no data for its use at this point. Where are we on time?
It's 9:02.
Done. Time flies when you're having fun.
Still technically, according to the video, you're at 59 minutes and 30 seconds.
Bingo. Last question. Anybody? Okay.
Needs to soak in a little bit with my sleep that I'm about to go get.
That's right. It's a process. Don't hesitate if you have questions. I was telling Shannon, I know some people can't always make it, whatever. You're tired, especially night people. Hopefully, anytime you have questions, don't hesitate to call me. Please make it before midnight.
1 in the morning. 2 a.m.
Please make it before midnight.
1 in the morning is our afternoon.
Yeah, whatever. But if I need to come, there's a group of people, for whatever reason, things have calmed down, I'm happy to come in anytime and talk to whoever about the topic. It's ongoing. This isn't something that's going to happen overnight. It takes practice, takes utility. Just as you
having those patients that you actually have to deal with it with.
Yeah.
That's what the I'm a very hands-on person, so like I can write stuff down all day, but until I have to deal with it and one of my patients
Sure.
to deal with it myself, that's when it's gonna sink.
You have to deal with it, every one of your patients all the time, every time.
I know, but sometimes, when you come in and you are more focused on their respiratory status than their cardiac status or
Sure.
something, you know what I mean? Like, sometimes we look at it more on certain patients than others.
Sure.
So those ones that we look at it more on is what I mean.
Sure, call me, I'll come in, happy to. But I would also encourage every single patient you look at, it applies. So as you give a fluid bolus, as you give their blood pressure med, you can take it in the reverse. They're a hypertensive patient. You're giving hydralazine, it affects here. You're giving beta blocker, it affects here. You're giving ACE inhibitor, it affects here. It also affects preload. So as you apply those medications, it's the exact same thing. Just write it down if you have to on a piece of paper. Just remember the formula. Just in your mind, just ask yourself that as you make those adjustments. And just see. It's not going to be every single person.
I'm annoying her apparently.
I'm fixing to throw my bottle in his
Go
hand.
ahead. Go ahead. We'll catch it on video. So, okay? Okay, thank you.